our speakers or their cameras so that we could all see them. We have Edie Hapner from USC, Voice and Swallowing Center. We have Michael Johns from USC, Voice and Swallowing Center, and Lucian Salika from Weill Cornell. They're joining us. Also online tonight with us is Matthew Nunheim. Matthew is my fellow in laryngology here at Mount Sinai Health System, and he's going to referee and answer some of the questions. I'm just waiting for my slides to advance. Somehow we stalled, but it will come. So, I'd like to start out with a few general comments. I was sitting in a meeting with Al Marotti about 5 years ago now, and it was an academy meeting of some sort, and the person before us just introduced himself at the table and said, so-and-so, otology, neuro-otology. And Al was next to introduce himself, and he quipped very quickly, Al Marotti, UW, laryngology, neurolaryngology. And I thought it was a very fitting comment because neurolaryngology is sort of the unrepresented stepchild of our field to some extent. We think about laryngology, we often think first about professional voice. And then we think about swallowing, and then maybe we think about neurolaryngology. So I think it's something we should all keep in the back of our minds. I think it's an active part of a lot of our practice. And it'll be fun tonight to talk about these tremors and quakes. It'll be particularly fun if I can get my slides to advance. I might just do an escape. Hang on a second, guys. Here we go. So my panelists, our question moderator, nothing to disclose, Al's funny quip, and our educational objectives then are really to define the scope of laryngeal movement disorders, to differentiate between SD, SD with tremor, vocal tremor, and vocal spasticity, and to discuss treatment options for different forms of laryngeal dystonia. You know, the neuroanatomy of voice and speech is complex. It's an intricate neural network. It is responsible for ensuring the main functions of the larynx for airway protection, cough, valsalva production, and voice. And the coordination of laryngeal function, therefore, is susceptible to disruption by neurological disorders. And we see some of the disorders in neurology that really affect or interrupt voice. So when a patient presents with a neurolaryngeal problem, I believe that a thorough neurologic evaluation should be routine, and that then endoscopic visualization of the larynx is crucial, and ancillary tests of swallowing function should be performed and breathing when indicated. The scope of neurolaryngology is often equated with laryngeal electromyography. Many people think of this as just, you know, paralysis or paresis, but really it's a lot more. It's movement disorders and degenerative neurologic diseases, and today we're going to focus on the movement disorder. But I'd like to just spend a moment thinking about the degenerative neurologic disorders. These can be broadly broken down into two types, those that create spasticity and those that create hypotonicity. The problem is once you get something that involves systems other than laryngeal dystonia, you start to see changes in speech along with changes in voice. And one of the biggest clues we have is that then these patients often have dysarthria. And so it's important because we frequently get patients referred in for dysphonia, and it's really dysarthria. So it's helpful, in my mind at least, to be able to separate voice and speech. And once you start to have speech issues, you have a broader neurologic process. Let's start with a patient example.
Rainbow is a division of bright light into many beautiful colors. These take the shape of a long round arch with its pads high above and its two ends apparently beyond the horizon. E, ah, oh. We hit the hammer hard. The puppy bit the tail. 6, sassy mice raced across the ice.
Another.
Okay. So to the panelists, Edie, how would you characterize this voice?
Well, she certainly has a pretty significant tremor in her voice. With the vocal instability, she couldn't even maintain a prolonged vowel. And in addition, she has kind of a chronic roughness and breathiness to her voice, but I think the primary feature was tremor.
Mike, Lucian, anything to add on that?
You know, when I listen to these patients, when I hear tremor, the other feature that I want to pay specific attention to, because your mind is immediately focused right on the tremor. So I want to also listen for breathiness and signs of atrophy. Of course, if we're going to corroborate with our laryngeal imaging, but these two, the patient population for tremor tends to be older, and our treatment goals can be a little bit divergent with glottal insufficiency and then laryngeal tremor and spasm. So I hear a little bit of breathiness too, that I didn't see a lot of atrophy to correlate with that on exam.
So this patient was obviously in her 70s, late 70s, and her symptoms had been present for 5 years. Lucian, does that suggest tremor or does that suggest SD to you?
Well, you know, I wanted to back up a little, Mark, because, you know, we just jumped to tremor because it's apparent to all of us. But maybe for people who don't listen to these voices all the time, it's a little harder to parse. And I wanted to point out that, you know, the central aspect here is disfluency of the voice. When people talk about disfluency, they can talk about speech, but really this voice is disfluent, and figuring out the pattern is the whole trick, because the first thing to understand is all this diagnosis is qualitative. I mean, there's no real objective testing that classifies people into one movement disorder or another. It's expert opinion, you know? Mm-hmm. So that history, to get back to your question, goes with either disorder, you know? And the thing that's most telling in this patient, which is super helpful for tremor, is the sustained vowel, because that's when you really pick up the periodicity of the thing.
All right.
Good points.
So she doesn't really complain of a lot of effort to speak. Does that sway your diagnosis one way or the other?
I mean, there's enough heterogeneity in these disorders that it could go with either diagnosis.
Edie, Mike? No, I mean, I'm surprised she doesn't complain of effort, because just as Lucian said, there's so much heterogeneity, but with tremor or with spasm, we often hear people complain of increased vocal effort. Either way.
All right. So the purpose of this was really to introduce this concept. Patients coming in with dysphonia. Does anybody hear any dysarthria in her voice?
I did.
No.
Besides the outrageous German accent?
Yeah.
Not dysarthric.
All right. So let's get patient or type number 2.
In the division of white light into many beautiful colors. These take the shape of a long, round arch with an pad high above and then 2 ends apparently beyond the horizon. Ta, 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 ta.
Stick your tongue out. Wiggle it back and forth.
Okay. So let's start with Lucian this time. How would you characterize this voice?
Voice is fine in this patient, or nearly fine. It's not the glaring thing about her presentation. The glaring thing about her presentation is her hypokinetic dysarthria.
Okay.
You know? And, you know, another little aspect that we made from that video very nicely, because you showed the whole patient's face, so much of the diagnosis goes into the totality of the patient. I mean, she's got this facial expression that doesn't change very much. It's a little bit odd. And you can see that she's struggling to enunciate and not succeeding very well.
Now, I didn't do any articulatory didochokinetics, right? But Edie, how would you characterize her dysarthria?
Well, if I was going to describe that speech, I'd say that she was hypernasal. She had imprecise articulation. She had excess and equal stress. She had slowed rate. And I actually heard some not like a spastic dysphonia, but a little bit more like a spastic dysarthria in her voice. And so to me, I couldn't, because I can't see well, I couldn't see her tongue and see if there was anything going on, any fasciculations, but that's a very concerning presentation to me.
Michael, anything to add?
Yeah, no, important to separate voice from speech as we're doing. And if we listen to her voice has a tight quality, but stable. And so for this particular patient, any sort of impairment in her ability to communicate really is going to be all related to her speech. And I just second the comments that Lucian and Edie made.
So I would add one thing. I would characterize her voice as spastic or strained.
Strained.
Separately from her dysarthria.
Yes.
That's the only distinction that I like to try, to hear the voice in distinction from what's going on from the dysarthria. And so let's talk then about, and I wanted to present these two cases off the bat because these are relative opposite ends of the spectrum for movement disorders. One's not even a movement disorder. Our first patient had a tremor of movement disorder. Our second patient had a degenerative neurological disease, motor neuron disease. But as a laryngologist and as an otolaryngologist, we've got to be able to distinguish these as quickly as possible, as well as our neurologists. So let's talk about movement disorders now. Movement disorders are involuntary, and they're unrelated to spasticity or weakness. It's a basal ganglia disorder, an extrapyramidal disease. And we can divide these into two categories, hyperkinetic and hypokinetic. The hyperkinetics are the tremors, the focal dystonias, the tics. And the hypokinetics then are things like Parkinson's. And all of these are basal ganglia disease that create movement disorders of the larynx, and in the case of Parkinson's disease, then systemically. So let's listen to our first patient.
The light strikes raindrops in the air. They act like a prism and form a rainbow. The rainbow is division of white light into many beautiful colors. These take the shape of a long round arc with its path high above and its two ends apparently beyond the horizon. 2, 3, 4, 5. 1, 2, 3, 4, 5. Harry hit the hammer hard. The puppy bit the tape. 6 sassy mice raced across the ice. We mow our lawn all year. The light strikes raindrops in the...
Okay. Now, I'm going to play a second video.
Welcome. Go ahead at the top.
When the sunlight strikes rainbows in the air, they act like a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors. These take the shape of a long, round arc, which is with its path high above, and its two ends apparently beyond the horizon.
Say you do it a little louder. How about a high pitch E?
1, 2, 3, 4, 5.
And whisper for me.
1, 2, 3, 1, 2, 3, 4, 5.
Now read those last 6 sentences.
Last 6. Harry hit the hammer hard. Puppy hit with tape. 6 sassy mice raced across the ice. We mow our lawn all year. We ate.
Okay. So to the panelists, How do you characterize these voices? Edie, let's start with you this time. You want to start with the first patient, the second patient, or do them together?
I can do them together and differentiate if you'd like.
I think that's my hope.
Okay. So the first patient presented essentially glottal stops or spasms on primarily voiced consonants and voice to voiceless consonants, and there was of course a strain quality associated with it, but strain wasn't the feature. The feature was the glottal stops that were quite consistent on vowel initial words. And so he was similar or characteristic of adductor spasmodic dysphonia. The second patient, again, we heard a little bit of the tremor in her voice or vocal instability in her voice when she was speaking. It was a lot more evident, as was pointed out before, on her sustained vowels. And I needed to hear a little bit more. If I was in the clinic with her, I would want to hear a little bit more, but I think I did hear some glottal stops on, again, some vowel-initiated words. I think the word was all that she had a little bit of trouble with. It was not nearly as significant as the first patient, but I think it was there also.
Lucian, something to add?
I agree with all of that. Just an interesting diagnostic feature that, in contrast to the tremor, where the sustained vowel really brings out the periodicity of the issue, here, the simpler the voice task, the better both of these patients do. And as you complexify the voice task, the more things fall apart. And that's another sort of diagnostic maneuver in these involuntary movement disorders that have a task specificity. Or if you can get the patient into unfamiliar vocal territory, just for instance, not reciting the Pledge of Allegiance or singing Happy Birthday or a sustained vowel, but something that requires them to concentrate on content, really disinhibits or releases the control of the voice and brings out the symptoms.
That brings up an interesting point and a question perhaps to the panel. What other things can you do when you have the patient actually in front of you to help differentiate between some of these conditions?
Okay. So here's where it's important to have some materials with you, working materials on hand in the clinic. So for each of the patients that we see, we'll certainly have an open dialogue and a conversation with the patient as we're taking a history. And I think Lucian's point about bringing them into unfamiliar content can bring out some of the features is actually really, really important. So we can't diminish the importance of the information that we get from just that dialogue. But then in addition to that, I think it's important to have a standard passage that you have a patient recite. Every single patient recites it every single time, and we use the rainbow passage, but there's several that are out there. We then like to add to that a sustained vowel, an ah, as long as they can hold it meaningfully, an e. We'll add projection, so either loud voicing or a big loud hey, because patients with adductor spasmodic dysphonia, their voices will typically improve with increasing subglottal pressure. And then we'll add some flexibility tasks. So a big whee, and try to bring them into higher pitch. And then beyond that, we want to have available to us phonetically loaded sentences, basically printed out. We've got vowel-laden sentences and sentences that are more voiceless to voiced sound-laden sentences that they can just read off. So we can do phonetic loading testing in addition to our standard sort of vocal battery right there on the fly. And so we can. So, anyways, I'll hold there, and then there's certain diagnoses that are associated with each of these components.
Oh, so Mike, don't hold there. I think I'm getting to the point that we've all decided that it's important to distinguish these minutia vocal characteristics. That our first patient was a fairly classic, simplified adductor spasmodic dysphonia. Correct?
Correct.
Would everyone agree with that?
Agree.
Our second patient, though, had something more going on. Now, her symptoms had been present for almost 20 years, and they did respond to botulinum toxin. And when the botulinum toxin wore off, she wanted another injection for the effort sound of her voice. So I think that I would characterize our second patient, I think as Edie was getting to, is adductor spasmodic dysphonia with tremor, right?
And maybe chronic constriction. She had kind of a chronically constricted quality where her voice, it can be confusing with muscle tension because she had a more consistency in her voice, whereas our first patient had very discrete breaks on vowel-laden phrases, such that we would see with our vowel-laden sentences and our phonetic loading.
And so was the overriding tremor or the associated tremor partly responsible for that? I think it's important when we have these movement disorders, because these are all laryngeal, these are both laryngeal dystonias, and I think at different ends of a spectrum here, right? And so is it important to distinguish these voice characteristics, and does it alter your treatment or the expectations of your treatment? Lucian, what are your thoughts on that comment? Sorry, Mike.
Yeah, so first of all, I think we would all agree that the presence of tremor makes everything more complicated. And the presence of hypophonia, sort of a glottic insufficiency component, makes everything more complicated because you're being asked to address different things. The basis of the difference with tremor really has to do with the CNS basis of the disease. You know, it's a cerebellar phenomenon, and the cerebellum is notoriously resistant to the afferent, efferent feedback that works so well for Botox and spasmodic dysphonia. So whereas you might actually, in spasmodic dysphonia, actually cause the spasms to completely disappear with a good round of Botox, all you're ever really going to do in tremor is decrease the amplitude.
Does that, and we'll get into this a little later, hopefully, does that include dystonic tremor as well?
So I'm a little bit of an outlier on this clear distinction between dystonic and essential tremor. And I don't think they can be so clearly distinguished. I'm sort of prepared to lump dystonic tremor closer to essential tremor than a dystonic phenomenon, and think about these things co-occurring. It helps me think about the disease. I mean, the reality is that these diseases don't read our textbooks.
So, and that's the purpose of our webinar tonight.
Yeah.
This is the main purpose. It does, in my mind, the presence of tremor does alter my expectations of treatment with these patients. Just as you said, Lucian, I don't feel, if I had that first gentleman, I felt like I could make him significantly better. And this second lady, I feel like I can get rid of some of her effort and the complete stops. But the tremor, whether we call it essential vocal tremor, essential tremor, or dystonic tremor, and the definition of dystonic tremor is just tremor associated with a vocal dystonia, essentially, is one of, just as you said, it's an expert opinion, right?
Well, the neurologists will actually refine the difference between dystonic tremor and essential tremor. You know, they tell you that essential tremor is 4 to 8 hertz with fairly regular amplitudes, whereas dystonic tremor goes a little bit faster with more unpredictable amplitudes. In other words, more variation from amplitude cycle to amplitude cycle.
So, but
neurologists love taxonomy. Whether that actually has clinical implications is a whole separate question.
So do you think it has clinical implications?
So we have a few limitations, right? Because we look at things from the point of view of, can we help this person essentially with botulinum toxin? And from that point of view, I don't think it matters. If I was attacking this the way the neurologists do with the various pharmacological agents, they know that the various dystonias and essential tremor respond differently to these agents. So it may make a difference if you look at it as a pharmacologically driven neurologist.
Okay. Michael.
So,
anything to add?
getting back to the first question, it really is critical to characterize these voices differently. First of all, that's the way that we make the diagnosis in these patients. And so, for example, our first patient, adductory breaks on vowel-laden phrases, that is characteristic of adductor type spasmodic dysphonia. If we hear breathy breaks on more consonant-laden phrases, so then we're thinking abductor type spasmodic dysphonia. Adding the prolonged phonation to draw out tremor is critically important because that changes our expectations for treatment for the patient. Patients need to have a good understanding of their disease in order to have reasonable expectations of treatment. The first patient is going to have a great result, I would predict, with botulinum toxin for his ADSD. And the second patient, we're looking for improvement and not complete elimination of symptoms, just because the tremor and the physical movements involve more than the glottis, involves the whole horn, if you will, typically.
And so I think that's important, because if we just inject these patients willy-nilly and throw all laryngeal dystonia into the same phenotype, and then we end up thinking we're not a good injector, that our Botox isn't working, and we set the expectations of the patients wrong. The other thing I would wonder is, as you brought up this point, Lucian, and Edie, please chime in here, is there something different in the neurological center or the CNS that's creating these differences? And if we don't separate the phenotypes, would that muddy the waters in our central nervous system studies, where we're trying to identify a difference between these patients and normal patients, or patients without voice disorders?
My comment about that is I don't think we know yet. I think it makes sense given what neurologists know and how they differentiate. I think it kind of speaks to us about doing perhaps a better job of differentiating the types if we can, but it won't be as simple as a perceptual evaluation, because I think perceptually it's really hard in some of these patients to hear the difference. It might be that we have to start considering adding spectrograms or things like that to our evals to actually either look at the frequency or look at the regularity of the tremor, not just somebody sits in the office and we say, oh yeah, you've got SD and tremor. And I think wouldn't it be fantastic if we could find out that there was a difference in treatment and we could actually better explain to our patients what outcomes they should expect, because we would know better?
Just as a counterpoint, I don't really think from a treatment standpoint it matters really whatsoever. We're basically treating the predominant pathologic feature of the voice to alleviate symptoms, regardless of how we're treating that. So I don't think it matters so much for day-to-day patient care, but I believe that it's really important that we as clinicians strive to categorize at least the phenomenological presentation of our patients accurately and consistently, just across sites, across individuals. So when we're trying to push the frontier of the field forward, we can do it more easily, because at least we're speaking the same language. We're talking about apples and apples versus apples and oranges. And at the end of the day, clinical studies are going to power future treatments, and we have to kind of know what we're treating, and we can at least start by classifying the patients consistently.
Mike, I think you're exactly right. And for somebody who's not in the world of movement disorders, I think it can be easily overlooked how arbitrary these disease categories are. I mean, adductor and abductor spasmodic dysphonia is a great example. There was an interesting paper a few years ago that argued that every patient with spasmodic dysphonia had elements of each, and just one predominated. And the reality is that our tool for this is botulinum toxin. And what do we have to do when we treat patients with botulinum toxin? We have to decide what group of muscles we're going to inject. So it sort of follows that we divide them into abductor and adductor, but that may not be the way the disease works.
Right. Lucian, I think that's an excellent point. I mean, it would be silly to think it's only going to affect the adductor muscles and not the abductors, or that it's always one or the other and not both. And if we look at the history and the writing on definition of spasmodic dysphonia, There's a laryngeal dystonia. We don't know if it's a spasm that's triggered by the act of speaking, a feedback, either a sensory or an auditory feedback, or a feed forward from higher cortical centers. But in 1968, Aronson broke it down into two subtypes, adductor and abductor, to split, right? So it's great to lump these patients into a category. All right, this is laryngeal dystonia. That's our broad category. Now let's split it so we can understand how we can treat the patient and understand how how the patient may respond to our treatment. It's very, in my mind, simplistic to think adductor or abductor only. And, in 1981, it was really considered by these authors a continuum of a mixed disorder, just like you were saying, Lucian. And I think those, yeah, I think those are great points, that there's something going on here coming from the CNS someplace that's causing this problem, whether it's feedback or feed forward, and we don't know. And why would it always just be abductors or adductors? So it's important, but I do think there are epidemiological symptoms that are helpful to me, at least. Usually the patients with spasmodic dysphonia have an insidious onset over a few years. It then stabilizes. It more prominently starts in the 3rd to 4th decade of life, in contrast to tremor, which more typically starts in the 6th or 7th decades of life. So I do think that. Now, both are women more commonly affected than men, but we've heard enough about the symptoms, the staccato breaks in the voice. And what is important is that epidemiologically, 20% to 30% of patients with focal dystonia, spasmodic dysphonia, will have an associated tremor of some sort, whether we call that a dystonic tremor or an essential vocal tremor, as Lucian discussed earlier. I think it's important that we, as laryngologists, as otolaryngologists and speech pathologists, understand that and try to characterize our patients that way so we can help them explain, as we've heard. Patients with the breaks only will probably get a more favorable response to Botox than those with breaks plus tremor. And I think that's important to counsel our patients, to counsel ourselves, to know what to expect from our treatment options. So we do know that spasmodic dysphonia has a reduction in voice-related quality of life, and there's a significant reduction in general health in terms of social functioning, mental health. And what is important about this is the patient's perception of what's going on with their social and mental health does not correlate at all with what we hear. And I think, Edie, you brought this point up nicely, right? Or and some to you, Lucian, too, that this is a perceptual diagnosis at this point, and what the patient is doing to compensate for the disorder makes it impossible for us to correlate what we're hearing with what the patient is feeling. And I first noticed this when I first got to San Francisco, and patients, let me just finish this one point, Matt. Patients were saying, well, the doctor told me it was only mild SD, so I feel guilty coming for treatment, right? That's something we need to avoid. Matt?
A question from the audience. Do you consider the direction of the tremor when visualized on flexible exam when you're determining how to treat this patient, specifically with Botox?
So if I can take that, tremor by definition is a bidirectional movement, is an oscillatory movement around a joint. If you have a rhythmic movement that has a very predominant direction, that's a myoclonic phenomenon. So, it's an odd question to ask about tremor.
I think that one of the questions may be, is the direction of the tremor, say, a vertical tremor, something caused by strap muscles as opposed to an anterior, posterior kind of thing? Yes.
I'm guessing the question is, when you perform laryngoscopy and you see tremor as predominantly a medial to lateral oscillation versus a vertical oscillation. Well, I think so. I think, yes, I do like to take note of that, because the patients who have lateral oscillation, this has been published, tend to have better response to botulinum toxin. But you can hear that too, because you're going to hear, when you get what we're now calling a lateral oscillation, you're going to hear glottal stops and glottal breaks. You're going to hear that. So that's something we can make better with Botox. And for those patients who've got more global movements of the larynx and the pharynx are going to have less glottal stops and more just instability into their voice. Versus I can make my second me better.
So, Mike, those are wonderful points. I think that when you have tremor with complete stops, it may imply more lateral movement. It's not always one-to-one, though. And early on in my career, I tried to look at that, whether or not the tremor extended outside the pharynx or remained inside the larynx, outside into the pharynx. And I, when it extended outside the larynx, only 1 in 5 got a significant benefit from Botox injections to the larynx. And when it stayed in the larynx, even if it was tremulous, 4 out of 5 got a significant response. So I think that goes to your point that when there's a lot of horizontal laryngeal tremor, whether it's dystonic or essential, you can help those patients with Botox. But I don't think I'm smart enough at this point in time to pick them out from their physical examination because they're so busy compensating for everything. They're trying to get their sound out, that what is the real relaxed laryngeal and pharyngeal motion, what is influenced by their attempts to compensate for it, and then what is influenced by my physical scope placement and trying to examine it too. So I don't know, your comments on that, Lucian? What are your thoughts?
I mean, okay. There's a lot of ambiguity in this examination, and there's a lot of patients that we embark on treatment without certainty about their diagnosis.
I like that. Michael?
I mean, I will endorse that 100%. And we're going to make treatment decisions in the setting of incomplete knowledge. And that's what the patients at the end of the day want. Our goal is to be my goal is to be transparent with the patients and let them know exactly what I'm thinking, what I'm leaning towards, and the decision-making why I'd recommend a certain initial approach.
And I think that's important because it sets the patient's expectations and our expectations. So picking out these different phenotypes of this laryngeal dystonia, I think is important, and explaining it to the patients, I think is important as well. I don't know if you all agree with me, but Edie?
Well, I agree with you. I don't think it's going to necessarily change our treatment now, but I think that there's a possibility, we just don't know yet, that it could have some impact, not as much changing the treatment as changing how we talk to the patient. Because I'm always so concerned about the patient having realistic expectations of the outcome and also understanding the process. That, this isn't a one and done, and I mean us getting it necessarily right the first time. So whatever we can do to improve our diagnosis, to me, is always going to improve our treatment.
All right.
Regarding diagnosis, a question from the audience. Are there any acoustic or aerodynamic measures that you find helpful in the differential diagnoses of these conditions?
So, there's been a lot of studies out there for a lot of years trying to use all different kinds of instrumental assessments to diagnose, I'm going to say, spasmodic dysphonia. And most of the aerodynamic measures that were originally studied, things like laryngeal resistance and subglottal pressure and phonation threshold pressure, ended up not being useful or as useful as they originally thought because of the variability of the disorder. It's not a stable disorder in spasmodic dysphonia. There's some work that is happening out of the STEP lab and also out of the University of Washington, where they're using RFF, which is, I won't even try and explain it, but it has to do with the onset of the vowel, and they're getting some decent results. I don't know recently, I haven't talked to Dr. Stepp or Dr. Edie about it, but they were getting some really decent results in the beginning and looking at that instrumental assessment measure and actually corresponding to vocal effort in spasmodic dysphonia. So I think there's things on the horizon. We don't use aerodynamics. If I was going to use anything, I might use spectrograms to look at tremor, but not anything in terms of a specific acoustic or aerodynamic test.
Yeah, I was going to second that sometimes spectrograms can show tremor that we may have a harder time eliciting and hearing. And as a follow-up to that, laryngeal EMG, whether it's a monopolar study or a bipolar study, concentric needle electrode, whatever, you will see the tremor fairly clearly on diagnostic laryngeal EMG.
So one point I want to make, because we're running a little bit short on time and we've got more material to go, is that treatment does, even in a broad group, treatment does improve quality of life. We have to remember that. And I think that's important, because we're not saving lives, but if we can improve quality, we have a reason for being. So we've spent a lot of time talking about treatment options for SD. And at this point, I'm going to skip those. Also, the clinical presentation, here we have a patient with abductor SD with tremor that was kindly sent to me by the former people at Emory Voice Center. But we know we can read or hear what that is in our practice.
The rainbow.
And the point I want to ask the panel, is the abductor form more difficult to treat than the adductor form? And do your treatment options vary?
So there are 3 reasons why abductor spasmodic dysphonia is harder to treat than adductor. Number 1, it's technically harder to inject the muscles. It just is harder to hit that muscle. Number 2, so there's more misses. Number 2, we're dose limited. We can't just keep increasing the dose because we're also going to run into airway problems. And the 3rd reason why it's harder to treat is that patients can't compensate for primarily abductor breaks. So with adductor breaks, you can compensate by increasing subglottal pressure, effectively being louder, and drive an otherwise tight glottis into oscillation. But with abductor SD, as soon as the vocal folds spread and you have glottal insufficiency, you can push as hard as you want. The only thing that's coming out is air. So those are the 3 reasons why I tell patients that ABSD is harder to treat than AD.
Lucian, would you care to comment?
Nothing to add.
All right. Edie, anything to add? No. All right. All right. Come on, slide, advance.
This is where a drum roll.
It's a drum roll. Well, who wants to talk about the treatment options?
For ABSD, I mean, yeah. It really comes down to, botulinum toxin injected into the posterior cricoarytenoid muscles at the present moment. Occasionally, I'll have a patient who seems to either have adjunctive benefit or sole benefit from injecting the cricothyroid muscles. And that is not a primary path of treatment for me with these patients, but it's something that I've added on when we've had suboptimal results from primarily trying to treat the PCA muscles. I tend to start with bilateral, fairly low dose injections, 2.5 units in both posterior cricoarytenoid muscles. It's not enough Botox that even if you hit both, that you're going to end up with airway distress, but you mitigate the problem that we have with miss rate.
All right.
So Mike, while we're waiting for the slide to change, just because you bring up the cricothyroid injection, there's nice work out there by Al Hillel that shows just how much heterogeneity there is within spasmodic dysphonia. I think he looked at a series of patients, I'm not sure how he chose them, but I imagine that they were patients who were just difficult to treat. And he showed all kinds of interesting muscular involvement, including people who had sort of interarytenoid spasmodic dysphonia and all kinds of things that the usual classification doesn't really allow for.
Can you guys hear me?
Yeah, we can hear you.
So I'm trying to end task. My Microsoft PowerPoint has frozen. We'll go on here then. I would disagree. I think that with 2.5 placed properly into the PCA, I've produced unilateral loss of abduction for 3 to 4 months. I would be concerned. I know Dr. Kaufman wrote originally about doing that bilaterally, doing one side with 7.5, and I think she then put a much higher dose, or lower dose rather, than the other side. Lucian, do you do bilateral injections?
For abductor?
Yes.
Yes, but I still stagger them.
Yes. No, I do too. I mean, I stagger them every 2-3 months apart.
Oh, I usually do 2 injections 2 weeks apart, and then the patient's good for that treatment cycle, however long it lasts. And some of these patients last surprisingly long, well beyond what you get in adductor spasmodic dysphonia.
That's interesting. I find my patients come, and I find my patients come every 10 to 14 or 16 weeks. And at that point, I usually alternate sides. I have a few patients who always get a better result with one side, so I'll inject that side more frequently, even for abductor or adductors. Has anybody found that?
One more time, Mark, or just repeat that.
I find that for abductor SD, I usually alternate injections roughly every 3 months. I'll do left PCA, then right PCA. And I'll always look to see if the PCA that I previously injected shows motion before I inject the other side. And my average starting injection for a PCA is 3.75, and my average dose is about 2.5 units. But I find that some patients get a better response always into the right PCA. So I'll inject the right PCA preferentially.
Oh yeah, I've found that too. And if a patient has a side that they feel is better, and maybe it's because I'm better on that side, it's hard to know. But if a patient feels that they're having, whether it's an adductory compartment directed injection or abductory, if I'm doing a unilateral alternating injection and they find that one side's better, I do exactly the same thing. I think this is the art of this kind of treatment. I think there's a lot of different algorithms which work as long as we're focused on patient symptoms, maximizing effect, and minimizing side effect.
Another question from the audience, if you will, asking about the role of voice therapy, behavioral intervention, discussions about breath support, all of those kind of things for SD, tremor, or a combination of the two. Are those helpful?
So, Mark, I know we're going to get to that a little further on. Do you want me to hold off, or?
No, go ahead now, because I just want to make a few more comments about some of these different orphan diseases now too.
Okay. So we tend to use voice therapy several different ways with both patients with ABSD, ADSD, and or any element of tremor. Sometimes patients will come in and they have a very high degree of secondary muscle tension in addition to the spasmodic dysphonia, maybe even a chronic constriction with some underlying spasm. And those are the people that we might recommend voice therapy, especially after their first injection, to help them get to a place of achieving the best voice possible. And what we know from some good studies that have been done a while ago, that a short course of voice therapy, not after every injection, but primarily one time, where you teach the patient how to, doing things like flow phonation, or finding ways to optimize glottal postures through any of the semi-occlusions or any of those other methods, and just actually reconnecting breathing that they might have forgotten how to breathe because they've been so tight and tense for so long. So a short course of therapy, 3 sessions, 4 sessions, at about a month post-Botox, primarily after the first session, will often both improve the ultimate outcome of the injection, better voice, and hopefully even maybe increase ever so slightly the duration between injections. There are, I don't want to take over here, but hopefully we can talk about too, because the patients that don't want to get Botox, because there certainly are a subset of people who are, at least in California, who are adamant about not putting botulinum toxin in their body. Mark, I see you smiling and shaking your head from your San Francisco days.
Yes.
And so I've had to do short courses of therapy with more people than I had done in the past, until they get to a place where we say, this is pretty much it, and this is how hard it's going to be forever. So now do you want to make a decision about going to Botox and seeing if you can get a better outcome? That's not uncommon out here.
All right.
Short course.
Lucian, you've been in New York a lot longer than I have. Do you find patients are resistant to Botox injections?
Well, I mean, you know, it's a self-selected sample. Yeah, there's a subset of patients who don't want botulinum toxin injections. But, you know, those are the patients we see once, you know. The ones we remember are the patients we see every 4 months.
Yeah.
Right?
Right.
And, you
But
know,
it seemed to
purists who are concerned that Botox is poison, I mean, you know, it's also all natural, right?
Right. Sausage poison. Yeah. So, all right, let's switch gears. I think that was really a very nice discussion of some of our clinical issues and our medical issues and our behavioral issues in treating patients with SD. And I think that I think we all agree that it's important to split out the phenotypes so that we can counsel ourselves, counsel our patients on types of therapies that may be useful and what to expect from treatment. So this is an odd disease here.
Rainbow is a division of white light into many beautiful colors.
Yes.
All right. So what did we hear, Lucian?
Well, we heard the consequences of sudden changes in pharyngeal configuration.
So pharyngeal myoclonus.
Right.
Right.
At a fairly low frequency, I think we got a hint of a left vocal fold immobility. I'm guessing this patient has had a brainstem stroke, which is the most common scenario in which we see this problem. And that you see one side of the pharynx, and sometimes both, just sort of ticking along at a fairly sort of low frequency while the vocal fold doesn't move or has reduced movement.
So this is known as pharyngeal myoclonus, palatal-pharyngeal laryngeal myoclonus. Repetitive muscle twitching may also involve the diaphragm and the ocular or limb muscles, and these are all synchronous motions. They're all doing this together, and it's most commonly caused by CVAs, just as you alluded to, Mike, where we get the Guillain-Barré triangle interruption. So the treatment, typically, would you clinicians offer this patient botulinum toxin? Think that there's anything to treat in this patient?
Well, I mean, it's very hard to inject the pharyngeal musculature without asking for trouble.
The palate has a little bit more forgiveness, but then you've got to ask, okay, what symptomatology that the patient's presenting with are you going to help with palatal injection? So I'm more inclined to do that for otologic symptoms. They've got clicking in their ear as a result of palatal myoclonus than for voice or resonance related issues, because the dose that it would take to have a positive effect is also a dose that's going to give you a lot of hypernasality.
And so, thank you. Let's talk, we only have a few minutes left. Let's talk a little bit about segmental dystonias. I have to go back out here.
Today? Okay.
My daughter.
Your daughter drove you. Okay. I know. Like that.
So this is really A segmental dystonia is a focal dystonia that involves one body segment. The head and neck is a segment, the upper extremity is another segment, lower extremity is another segment. And in the head and neck, the oral mandibular dystonia with blepharospasm is known as Meig's syndrome. What we saw here was an internet example, a YouTube example of a fairly severe case of Meig's syndrome, and it's triggered by speaking or articulation and sometimes even light exposure. And this was originally described by Henry Meige, a French neurologist. Women, again, like in most movement disorders, are more commonly affected than men, and it can onset in 40 to 70-year-old patients. So, how common is this in your practice?
Well, so it's not as common as spasmodic dysphonia, but because neurologists are very reluctant to wade into the head and neck with botulinum toxin, have a population of patients with, on the continuum of this disorder, that come for routine treatment.
And so what do you do for them?
Well, so again, important to have back and forth with the neurologists about what they can achieve with systemic medications. Because often the treatment of some of these muscles with botulinum toxin is either quartz morbidity or just can't be done. I view my job as achieving symptomatic improvement where I can, when I can treat the affected end organ. And that potential is variable from patient to patient, but on the one hand, it's frustrating that botulinum toxin, we keep coming back to botulinum toxin, it's our hammer and everything ends up looking like a nail. But on the other hand, it's super interesting and challenging and tests your knowledge of anatomy and physiology to learn how to use Botox subtly in these patients with multiple muscle involvement.
I think that, I'll ask your opinion on this, Edie. I try in my practice to separate laryngeal dystonia, even though it's oculopharyngeal and laryngeal dystonia in this. Some patients have more of a laryngeal component, some patients have more of a pharyngeal component. And I try to separate that out because I've not had good responses to tongue-based injections or lateral pharyngeal wall injections or strap muscle injections for these patients. And so I always end up producing more dysphagia. So if I can hear laryngeal dystonia as a significant component, I will attempt to inject the larynx. And I think those are the patients I can help. I don't know your thoughts on that, Edie.
Go ahead.
I think that you shouldn't underestimate that, Mark, because it's really, there is a tendency to see patients, just like this example that you just showed, who has a very significant movement disorder, and basically throw your hands up and say, you know what, we're never going to be able to fix that. And you know what, presently, we can't. However, getting to your point, if you can treat a component of their symptomatology that's causing them problems, you will improve other elements as well. For example, our lady who is our spastic dysarthria patient at the very beginning, or this patient who's got incredible laryngeal tightness, just by reducing the strain and the spasm to the laryngeal level, oftentimes they're more intelligible despite the other movements that they have.
And not only that, but sometimes these movements that are entrained with one another, if you treat some type of core thing, like if you have a Meige that's clearly triggered by voice use, and you treat the larynx, that eye blinking will lessen. And the other point I'll make is it's not all about voice. This is oromandibular dystonia. Some of these patients have these horrible crossbite deformities that gives them intense temporomandibular pain. And when you treat the pterygoids that have nothing to do with voice, you have achieved a huge symptomatic improvement.
Not as the treater, but as the person that often works with people after treatment with oromandibular dystonia, Lucian, the pterygoids make a huge difference in these people. And people that have gone through jaw surgeries for these things, but I just have to get it in before we have to close. I will work with some people with oromandibular dystonia to help them with those sensory tricks that makes life better. Like putting your finger here, putting your thumb here, and you have to change it up because this dystonia is so sensitive to sensory tricks. But if I have an actor, which I do, who walks in the door and he's got oral mandibular dystonia and getting about a 50% improvement with injections, which I think is great, by the way, and I can give him a little bit more improvement with some of these silly things that he might not have thought of, that he can stick a pipe between his teeth and say his lines, then I feel like I'm helping somebody improve their quality of life also.
So I think that, we're approaching 9 o'clock and we have a lot more material, but I want to thank all of the panelists and the audience for their participation. I think this has been a great start to this discussion. I want to leave this one question up there because we're not going to have time to answer it. And we don't get closure on this, guys, and I'm sorry for that. How helpful is EMG in the diagnosis or management of movement disorders of voice? I mean, that's a whole discussion hour, I think, in itself, possibly. So I'd like to offer my panelists.
Mark, that's not a discussion, that's a bar fight.
I think we're all too polite to fight. But, I'd like to offer, any closing comments, Edie, Mike, Lucian?
Just everyone take the time and the energy to help diagnose these people and treat them. It's a population in need of our care because we're the ones that are doing it. And thank you for having me, Mark. I appreciate it.
Thank you for participating. Lucian, Michael? Thank you, everybody. Have a good evening.
Bye.